Fahd Medical City. The lecture title is Refractory Hypoxemia, What's Next? So, Dr. Ahmed, try to share your slides, please.
Just 1 minute.
Doctor, please.
Can you see my slides?
Okay, so the title of the talk today is Refractory Respiratory Failure. What's next? It will be presented by Dr. Ahmed Khalifa. He is a senior fellow from King Fahd Medical City, and I'll be moderating. This is Dr. Nadal Jassim. I'm consultant at King Fahd Medical City and the Pediatric Ecmo leader. Thank you. تفضل Dr. Ahmed.
Okay, good evening, everyone. Thank you, Dr. Nadal, for the introduction. So we're happy actually to present for you one of our cases that we had, and a bit of a talk after that. We'll talk about refractory respiratory failure, just mentioned by Dr. Nadal Jassim. Actually, we will start our talk with the case presentation, and then we'll talk a little bit about introduction for VV ECMO, followed by some indications and contraindications for using ECMO. And in the end, a couple of slides about respiratory management on VV ECMO. Regarding our case presentation, actually, we will start by this girl. She's a 10-month-old, 8 kg. She was previously healthy, and she was in her usual state of health till 30th of March, when she actually was playing in her grandmother's house with some toys, and then suddenly a foreign body got dislodged in her mouth. Her grandmother, at that time, she tried to remove it, but unfortunately it was pushed further, and the patient became cyanosed, unable to breathe. So the family, they took her to the nearest hospital, and in the way they were performing mouth-to-mouth blow, trying to retrieve her breathing. So a quick history in the previous hospital, in the referring hospital, there was a history of arrest for like 20 to 30 minutes. She required CPR, and in the referring hospital, she got intubated and ventilated there. During intubation, there was a milk noticed coming from the intratracheal tube, and she developed a refractory hypoxia and supported with a high ventilatory PEEP reaching 17. So after that, she developed bilateral pneumothorax, required 1 right side chest tube and 2 left side chest tubes. She stayed there for like 1 day and then transferred as a life-saving to our hospital, and initially accepted by the ENT team as a case of foreign body aspiration for removal. So at the presentation to our hospital upon arrival, it was on 1st of April, she was sedated with fentanyl and midazolam infusions. She was intubated in high mechanical ventilatory settings, intubated with a fork of the tube, and in pressure control settings. Her initial X-ray, as you can see here, showed a lung collapse with bilateral pneumothorax and foreign body in the right main bronchus, which looked like initially as a paper clip. She was supported at that time with dopamine infusion, and her initial signs was showing tachycardia, borderline blood pressure with tachypnea and desaturation down to 80s. So in emergency department, the PICU team assessed the patient. Sedation were optimized at that time. Epinephrine infusion also was started and titrated according to her blood pressure. And initial blood gases showed both actually pictures of metabolic and respiratory acidosis, as you can see in the table here. In aiming for improving her oxygenation and respiratory status, she was initiated on high-frequency mechanical ventilation along with nitric oxide. Unfortunately, she did not improve her oxygenation or respiratory acidosis, as you can see in the blood gases following the high-frequency initiation. It was escalated to frequency of 5, amplitude of 53, MAP of 25, and nitric oxide at that time was 20 parts per million. The vital signs was showed heart rate of 150, blood pressure 95/51, respiratory rate of 30, and saturation ranging between 60 and 80s, with some saturation improvement noticed up to 80s with high pressure bagging. This graph just to show you that the initial hours vitals for this patient, I'd like to concentrate on the saturation in the brown line. It was persistently low, between 60s and 80s. And the heart rate actually initially was tachycardic, but then improved with some sedation and enterobic support titrations. So we went and assessed the patient systematically. She was having reactive pupils, responsive before starting the paralysis, and there was no head images at that time. And respiratory wise, she was having obstructive right lung, possibly aspiration related, and high ventilatory setting with air leak bilaterally along with the chest tubes there. She was on enterobic support with a borderline blood pressure. Lactate at that point was 1.7. Her initial other organ assessment was acceptable, except for some derangement in the renal and liver enzymes. So ENT saw the patient, and at that time, their opinion was that the patient needs to be stabilized before rigid bronchoscopy and foreign body removal, and anesthesia also had the same opinion and a plan for backup ECMO in the OR. ECMO team were consulted at that time, and the patient was assessed, and the decision was to go for emergent VV ECMO for both the procedure and the refractory respiratory failure at that point. The challenges we're facing the ECMO team at that time and to start VV ECMO for this patient were mainly the unknown neurological status with the history of arrest and prolonged hypoxemia in the referring hospitals. Adding to that, there is no training images at that time. Along with that, the patient size was less than 10 kg, which is a potential challenge during cannulation for the ECMO in such weight. So for preparation of ECMO, an Ecmo Callout was activated. Actually, Ecmo Callout is a process that we have in which will involve the NTUT team, including nurses, blood bank, hematology lab, and the perfusionist, to be ready and on the spot for initiating an ECMO for any patient. The routine preparation, we reviewed the contraindications and we prepared the patient, including IV access, optimizing hemoglobin, and other systematic review. We did a cardiac and vascular evaluation by ultrasound. Also a standby support from pediatric and vascular surgery in case any challenges were faced during cannulation. Also, the setting were prepared for ECMO, including the room in the OR and the room in the ICU. An aim to transfer the patient from the ER to OR, we had to shift the patient from high frequency ventilation to conventional mechanical ventilation. We put an impression control in high settings initially. Then she was shifted to the cardiothoracic operation room at afternoon 30. The vitals initially in the OR were showing a heart rate of 150 to 160 and saturation of 75 to 85 with a good blood pressure at that time. So cannulation proceeded, and ultrasound guided cannulation was done by the pediatric ICU team at the OR, and we used like a right femoral cannula of 10 French and the right internal jugular cannula of 12 French at that time. The cannula position after insertion was confirmed by X-ray and same time during the OR. This X-ray, actually you can see the right internal jugular cannula, which is a 12 French, and the right femoral cannula, which is a 10 French. And prior to connecting the patient to ECMO, she suddenly had a desaturation of down to 40s. We did it like a troubleshooting for acute hypoxia, but we failed to optimize it. But eventually the patient improved maximum to 60s of saturation. At that point, VV ECMO was initiated, and saturation after initiation improved up to 93%. And the patient was pushed at that time to resting mechanical ventilation settings. So for the aim of orientation, and before we continue with the progression of our patient, we'll just talk a brief about ECMO. ECMO usually is a device that drains blood from the circulatory system. In our case, we use the VV ECMO, which is a venous ECMO, draining the blood from the femoral vein, going to a pump that pushes the blood to an oxygenator and return it through usually the internal jugular vein. Though in certain circumstances, like a different circulation used, like in our patient, we drain the blood from the right internal jugular vein and we return the blood through the right femoral vein. These are the pictures for the device that we have in our hospital. This is the main module, which where you can put the settings and monitor the pressures for the ECMO. This is the pump, and there is also a breathing pressure monitor here. And this is the oxygenator, and also there is a sensor like post-oxygenator pressure monitor. And this set for both the oxygen flow, for oxygen FiO2 concentration provided, and for the sweep gas, where you can define the flow. And this tube, actually, you can see the gas inlet coming from the source to the oxygenator. So ECMO for our patient was initiated initially, as you can see in the picture. These are the settings. It was connected and started with a flow of 100 per kg per minute. The speed initially was started at 5,250 RPM to provide that flow. FiO2 in the beginning was 100 with initial readings of pressures P1, which is a drainage pressure from a patient, negative 12 to 18. P2, pre-oxygenator pressure, it was measuring 81 to 82. And P3, which is stand for post-oxygenator pressure, reaching 53 to 56. And a delta pressure of 26 to 27, which was acceptable to us at that point. So after initiating ECMO and stabilizing the patient, the ENT had the opportunity to extubate the patient as she was stable, and they were able to manipulate freely to easily extract the foreign body that was stuck to the right, the main bronchus, as you can see in the video here. She was extubated, scoped, and foreign body was removed. O2 saturation was ranging between 85 to 90 during the procedure, and after that, re-intubation was done, and the decision was to rest the lungs for a few days. Interestingly, the foreign body was a small LED light, which you can see in the toys or some devices that was extracted from the right main bronchus. So the patient trends of blood pressure before and after ECMO initiation showed significant improvement after ECMO. Initially, she was having significant respiratory acidosis of pH 7.06 and CO2 of 79 that improved gradually after initiation of ECMO. So a patient was transferred from OR to the PICU, which was really an important moment. All the team had to be around the patient, and the ICU room was already set up with a hemodynamic monitor and near-infrared spectroscopy. The patient's status in the ICU, she was sedated and paralyzed at day 1. Pupils were reactive and equal. Head ultrasound was requested and it was unremarkable. Hemodynamically, she was having normal blood pressure parameter and epinephrine with some titrations. Respiratory-wise, she was kept in resting settings, avoiding any more paratrauma and improving ABGs at that time. We were accepting saturation of more than 85, and the patient was achieving that, and accepted PCO2 was 40 to 50s. She was kept MBO and omeprazole infusion along with IV fluid, and Lasix planned to be initiated early in the phase and targeting negative balance. Hematology-wise, heparin was an infusion initiated. We were monitoring the activated clotting time with an non-bleeding protocol ranges. And she was kept on the same antibiotic as she was ER, which include tazocine and vancomycin, and all cultures was sent. Regarding ECMO, the flow and the pressure were acceptable as well. In our care, we were following the Kfmc Pediatric Ecmo Management Guideline. It is summarized in this table. We have all these points and with an acceptable range, and we were reviewing this on a daily basis for our patient. What we are doing in the daily rounds for this patient, we have the team usually involved in the round are PICU consultants, an Ecmo consultant, and an assistant or fellow taking care for the patient, along with an Ecmo nurse, and another primary nurse, a pediatric perfusionist, and a respiratory therapist, all gathered doing a daily round for this patient. The main point discussed in the daily round were systematic review from A to Z, along with Ecmo parameters and settings, also reviewing the readiness of weaning from Ecmo and reviewing the potential complications that might happen in regard to the patient. So this is the day 2 and a day 3 X-ray. There was some progression and improvement in the aeration in the lungs. And these X-rays were on VV ECMO. As you can see, the cannulas are there. So regarding to the progress, like the patient was, after day 1, kept off paralysis. Near-infrared spectroscopy were initially stable. And the daily point of care echo was done by our team, PICU at bedside, with we're doing also daily regular pulmonary hygiene therapy and lung recovery and readiness for weaning assist regularly for this patient. There was some congestion in the right lower limb at the same limb with the cannula inserted, and there was a stable congestion with good pulses and perfusion all through the stay of the patient. Day 2, we had a drop of near-infrared spectroscopy of less than down to 45%. Our acceptable range actually was in 50s and above. So for this, the patient was assessed systematically. There was no observed seizures. Head ultrasound was repeated, and there was no bleeding. She had at that point a borderline perfusion with low mixed oxygen saturation, and that improved after some boluses of fluid. Echo was done also at bedside. It was revealing a good function with some pericardial effusion. And along with that, some small dose of vasoactive support was added, and official echo was requested at that point. This patient also were considered to be septic, so she was recultured and started the meropenem. And later on, these cultures came to be negative. Okay, so this chart representing the ventilatory setting for our patient. For the first 3 days on ECMO, we kept the patient in resting settings. Later on, from day 4 to day 6 and 8, you can see in the red line there is some improvement in the compliance showed by the improvement in the measured tidal volume given to the patient by the mechanical ventilator. Like at day 6, we reached a good point. So at ECMO weaning point at the time were considered. These 2 graphs representing the ECMO settings. The second graph here is about the VV ECMO pressures, P1, P2, P3, and delta pressures, the same pressures we talked about previously. These pressures were actually maintained within the target range all through the days on VV ECMO. And in regard to the settings, she was initially in the same settings. Then at the day 6, when there's some improvement, we started weaning the sweep down till we reached the point of decannulation at the end of the day 7. Regarding ECMO weaning, we started the guideline of FiO2 and the sweep starting from day 5, since as we noticed there's good pulmonary function and good tidal volume started to recover gradually. By day 7, the sweep gas was off. FiO2 was reaching 21%, which is the room air, while the flow was kept running. Heparin infusion stopped before decannulation. Then we proceeded with the decannulation at bedside, since all the gases and lung mechanics were acceptable like a few hours after reaching these off settings of VV ECMO. These are the X-rays of the first X-ray here at day 1 of ECMO. And before the cannulation, you can see the X-ray and the improvement in the aeration in the lungs and the improvement of the air leak there. So regarding the patient progress post-ECMO decannulation, the echo was repeated, showing mild pericardial effusion posteriorly and trivially anteriorly, which is an improved one. And the last chest tube was removed on day 9, and the patient was extubated the following day at day 10. The patient was transferred to the ward at day 13, post-PICU admission, which is the whole ICU stay. Venous Doppler was done for the right lower limb, as there was congestion at that point, and jugular vein and the incision site. There was some narrowing in the right internal jugular vein, and also there was a right femoral vein Doppler showing external iliac and common femoral thrombosis, for which this patient was started in enoxaparin and was guided by the hematology service at that point. This chart summarizes our patient. So we had a patient presented with a conventional mechanical ventilation with a mixed respiratory failure despite high ventilatory support and with barotrauma. Ecmo was initiated and foreign body was removed. And she stayed for 7 days on both conventional mechanical ventilation and Ecmo, waiting for lungs recovery. After that, Ecmo was disconnected or decannulated, and she continued in conventional mechanical ventilation for an extra 2 days. And after decannulation, after that, she was extubated and transferred to the ward after 13 days from PICU admission. Just to show you, this is the first X-ray at the presentation with the foreign body at the right main bronchus before cannulation of Ecmo. And this is the X-ray post-cannulation and before transferring the patient to the ward, showing clear improvement in the lungs with a good parenchyma. This is our patient actually in the ward after the cannulation. And we recently also reached with the family, and she was healthy and active child. So we will do some VV ECMO overview and some points that we mentioned at the beginning of our presentation. So in regard to VV ECMO, we'll show you some graphs also from the ELSO organization. It's a modality for extracorporeal life support that provides support for severe reversible respiratory failure as a bridging to recovery or transplant if failed conventional support. This graphs shows you from 1990 till 2020 the increment of of number of centers that is increasing, and use of ECMO over the last years. Here I would like to show you also that the survival to DC from ECMO is actually a good number. You can see here in neonatal, pediatric, and adults. For the pulmonary cases, there's a good numbers that mentioned the statistics of ELSO organization, reaching 73 and 60s for pediatric survival to decannulation or transfer. So what about ECMO and foreign body? Actually, Anton Martin and his colleagues in 2019, they made a study about 4 cases that they had in their center, and also they reviewed the literature and reviewed also the ELSO registry for similar cases. They found a lot of cases where VV ECMO were used for respiratory failure secondary to foreign body aspiration. And in the conclusion for this study, they mentioned that death is usually related to hypoxemic respiratory arrest caused by airway occlusion before or during foreign body bronchoscopic extraction, and that ECMO is useful to manage these life-threatening complications and stabilizing the patient for these procedures. And also that one of the things that they noticed that ECMO support courses were short, regardless of ECMO type that was used for the patient. And the survival of more than 90% was noticed in these cases up to hospital discharge. So in regard to our patient, we had a foreign body aspiration leading to respiratory failure, which was the trigger for the ECMO activation. But our child has many contributing factors added to his sequence, like the unknown neurological status and the small size for our patient, which makes challenges actually for starting the ECMO. And regarding to the cannulation of VV-ECMO, this graph demonstrates for you the multiple techniques that can be used. Actually, you can use either two single lumen cannulas, like in picture A and picture B. You can use both femoral veins, and you can use femoral and internal jugular vein, like in our case. The other option is to use a double lumen single cannula that can go through the internal jugular vein, one lumen for drainage and the other lumen for return. So the next question comes saying, who will insert the cannula? So most of the big centers usually have surgeons that they can do it. It can be done by an open technique, semi-open technique, or even percutaneous technique. Like in this picture, like an open technique was done. Some other centers are being done by an interventional radiologist or interventional cardiologist, or also can be done percutaneously, like in the picture here, by the intensivists themselves, like what happened to our patient. The next thing comes to say that percutaneous cannulation is limited despite less bleeding and better wound healing. And this is a challenge because small vessels in children is difficult to cannulate sometimes, especially using large cannulas like the VV-ECMO cannulas. The good thing is that ultrasound was mentioned in the literature before that allows assessment for vein size per cannulation, and it is a helpful guide for the physician upon installation of the cannula. So we talked about VV-ECMO and how it's initiated. What about the disadvantages of VV-ECMO? Some disadvantages or even challenges that can be faced for VV-ECMO is that usually you are providing lower systemic PO2. There is a chance of recirculation, and there is also the femoral leg edema and venous thrombosis that might happen as a complication of cannulation, and also the no cardiac support provided for the patients. It's only lung support. Higher flows sometimes are required for patients who, and even higher in cases that the patient is septic, not only respiratory. They will need to provide further higher flow to provide further oxygenation for the patient. So what about the indications for ECMO? The also guidelines and also Erickson in 2019 in their study, they mentioned a couple of indications. The most thing is that a potentially reversible etiology of respiratory failure on mechanical ventilation equal or less than 7 days, plus one of the following. Like first thing is like a patient who's having rapidly worsening oxygenation index or oxygenation index more than 40. Just to keep in mind for those who are not aware, oxygenation index can be calculated by using the mean airway pressure multiplied by the FiO2 multiplied by 100 divided by the PaO2. The second thing that can be indication is the PaO2 FiO2 ratio of less than 100, despite providing maximal ventilatory support for the patient. And the next comes is the respiratory failure with barotrauma, like an air leak syndrome, pneumothorax, emphysema that are difficult to control. And in the end, also hypercarbic acidosis, pH of less than 7.2, despite maximum ventilatory support. These are the major indications that was mentioned in the also and in this study also. Regarding to the contraindications, on the other hand, also these are from the also Red Book in 2015 and from a study was published by Grant and his ETAL in 2018. Some contraindications can be considered like a reversibility of the disease condition. Another thing is high mortality rate for the disease, like incurable malignancies, severe brain injuries or congenital brain malformation resulting in disabilities, and also presence of multi-organ failure. And the other thing is that ongoing hemorrhagic condition or significant intracranial bleed in the presence of mass effect. You may find some other contraindications, but these are the major things that mentioned in these two references. What about limitations? Sometimes it's not a contraindication, but a limitation given the poor prognosis for the patient. like long ventilatory days with high pressure ventilation. It can be considered a limitation for the ECMO because of the poor prognosis. Also, chronic lung disease, especially in the presence of secondary pulmonary hypertension, premature babies less than 34 weeks are a limitation. Pulmonary infiltrates associated with allogenic bone marrow recipients and vascular anomalies or technical difficulties in cannulation. Limitations are not restricted to these 5. There is some other limitations, and now some other studies are even discussing the role of ECMO in some of these cases. So in the end, what about the respiratory management on ECMO patients? The most important thing I would talk about here is resting settings, as it was mentioned multiple times in this talk. This study is by Grant and his colleagues in 2018. It was mainly on adult patients, but it speaks about the same idea. They made a protocol, it's called an improved protocol, which stands for ECMO for protective ventilation. The idea from this protocol is to provide a setting for the mechanical ventilatory settings, maintaining a good support for the lungs while avoiding lung injury. And what they mentioned that improved protocol for lung protection will lead to near complete whiteout and chest radiograph, but patient recovery is ultimately determined by the improvement in the lung compliance and the received tidal volume. The compliance is indirectly measured by noting the progressive increase in the tidal volume, and serial chest radiographs are followed daily to assure that any whiteout is resolving and the lungs are aerated appropriately. The study, they have put this like algorithm or flow graph, like summarizing the steps of ECMO. So the first thing is initiation of VV ECMO and the improved protocol that they mentioned, treating the underlying pathology, maintaining the hemodynamic support, and correcting the metabolic disturbances. After that, waiting for a clinical recovery assessment. As we have done for our patients, like a daily assessment thing, we will assess for lung compliance and for the improvement in the received tidal volume and also in the chest radiograph normalization. After that, the point of discontinuation of the resting settings will come, then like increasing the setting gradually, then starting weaning ECMO later on, the later steps. Last study done by Dennis and his colleagues in 2017. It's an international survey on ventilator practice among extracranial membrane oxygenation centers. What they mentioned is that it's about recruitment and mechanical ventilatory settings on ECMO, actually. They found that the most common mode of ventilation during ECMO is the pressure control. And there was a trend toward an increasing use of bi-level ventilation, particularly in lung recruitment. And also there is some trends toward performing bronchoscopy for patients on ECMO. But in the end, still, recruitment while in VV ECMO, especially in the initial days, is controversial. So I would like to end my talk here. Thank you for listening, and the door is open for questions, comments. Thank you very much.
Thanks so much, Dr. Ahmed, for this great presentation. Well done. Comments and questions from audience. I'll start with Dr. Hani Timsah. Unmute yourself, please, and share with your comment or question.
Assalamu alaikum.
Wa alaikum assalam wa rahmah. For the host, can you allow people to unmute themselves?
Okay, now you can hear me again.
Yeah.
Oops. No, you will need to.
Oh, malayo.
My dear, just allow people to unmute themselves whenever they want to speak.
Hello. Yes. So please only allow the one who raised the hand to talk, and the others, please keep your mics muted because I'm having so much echo inside. Please, those who are not sharing the mic, please keep muted. So I'm just first of all congratulating this achievement. How's the neurological status for this baby? You mentioned she's doing fine, what I understood from your side, Dr. Ahmed.
Yes, actually, she was doing pretty good, and I was contacted with the family recently, and she's like an active child.
MashaAllah.
Very happy about her.
So I think you may consider having like a follow-up neurological clinic for these patients post-ECMO. I'm not sure if you're having that. That's a wonderful, just a suggestion. And يعطيكم العافية. I really appreciate the efforts, and I hope that hopefully one day we will have an outreach ECMO for other centers throughout. Again, thank you all.
Thanks so much, Dr. Hani. We're having a plan, inshallah. For follow-up neuroclinic, this patient came from the north, so we tend to contact people who had the ECMO from the VAs. This is the first VV, and we got the number, and we just checked the patient clinically, even in the hospital. Like before discharge, we were visiting upstairs. She was like, since extubation, she was moving all limbs, and she is able to contact and follow. Thanks so much. Other comments, Dr. Ahmed?
Assalamu alaikum. Thank you very much, team, for a very very good presentation and the dedication you guys showed in treating this patient. My comment was that you mentioned that the patient came to you with the history of resuscitation for a cardiac arrest, which was for 20 to 30 minutes. And there must have been a dilemma with this prolonged period of resuscitation. I'm sure you had a dilemma of deciding should you go further with ECMO in this patient or not, and there was no neuroimaging at that time. Did you at any point thought of putting this patient on brain protective strategy or not? And I think I agree with Dr. Hani that I think this patient will need a regular follow-up with the neurology clinic for further development. Thank you very much.
Thanks so much for your comment. This is an excellent point to raise. Honestly speaking, we were not sure about the 20-30 minutes because we assessed all organs. Lactate was okay, and there was no other organ injured. Apart from mild increase in urea, like all organs after a day and a half from arrival from the event till arrive to our hospital were like okay. So it was a question mark. Like as you mentioned, it was real dilemma to choose this patient, especially that we can't move this patient for any neuroimaging. So the choice was we do what we have to do to as rescue ECMO to get the foreign body out, but eventually there was like more than one factor to keep on going with the ECMO, and we take it from there. Dr. Ahmed have mentioned that the pupils were equal reactive. The temperature were not strictly like gone, but like we went through, except like normal temperature. We did not go for targeted intentional temperature management, but we were on ongoing with the NIRS, and it was 60s all the time, above 50s, until we had that event, and the paralysis were off from the second day, and all of that purposes to assess for the neurological status. And the plan was, whenever we find issues or seizures or any problems from neuro-wise, to go for CT and reassess the child from continuous support point of view. Again, all patients who had VA ECMOs in our center, we were like entering MRI as follow-up for them, not only neurology assessment, but this patient is like from outside Riyadh. So that's why. But it's a great suggestion again, and willing to follow up. Dr. Iman, have comment or question? تفضلي.
Yes, assalamu alaikum jami'an. Thank you very much for this wonderful lecture. Just I would like to ask about if this child was have the chance to be ventilated using double lumen ET tube, would this have make a difference? Because both lungs were subjected to high settings, resulting in this paratrauma, pneumothorax, and this was not I think it was not possible at the original hospital, but was it possible to give a trial in your hospital before the ECMO?
To my knowledge, as ECMO consultation, that double lumen ETT was not proposed for this weight for this child. Again, other patients who are having problems considering one lung ventilation was for certain age, for certain weight, after a meeting with pulmonology and anesthesia for another case. So
no, my question, if it was given initially.
Yeah,
initially,
to say that,
because he has healthy lungs.
Yeah, to say it clear, I'm not sure if this is proposed from the primary team initially, but ENT and pulmonology were both involved from that perspective, and the plan was we have to go for a scope, remove the foreign body, and to do that, they can't like manipulate in the airway at all, except the choice is rescue ECMO to support the lungs before doing anything in the OR. Should my team have any input from the primary treating team, that will be great, if there's any information.
Yeah, if allow me, Dr. Nada, just to tell you something. Yes, tube for ventilation one lungs is not available in the market, and what's available is for the weight at least 25 kilo, and it was not available for this 8 kilogram. So I cannot ventilate. The tube is not manufactured. Actually, it's not present in our hospital. I don't know if other hospital has tube, but this is one of the options what we thought about it, but it was difficult to be done because of unavailability and the size of the patient.
I mean, we could not have used the same tube and proceed to the left lung, advance into the lung, left main bronchus.
And adding to that, this is a good point. Need to think about it, but the same things. The lung is not healthy. The patient has serous tube and also has a picture of aspiration pneumonia. Both lung is not healthy. It's not only one lung.
No, my assumption was if it was started from the beginning, before the damage happened.
No, this is what a patient came with in bad shape, as mentioned in the presentation, with the saturation 60s, 70s, and very sick lung is not improving, and with the foreign body, this is challenging all over. And ECMO was called as a rescue treatment for this patient. So it was very hard to do any manipulation. Even removing the body or excavating the patient that time is a high risk for arrest even.
Yes, yes. Okay, thank you.
Thanks so much, Dr. Iman. Do we have comment or question from Dr. Shaban Al-Hassan? I'm not sure if I'm pronouncing it right.
Yeah, assalamu alaikum.
Yeah,
I'm Dr. Al-Hassan, pediatric intensivist. I'm just I need to just I need to thank all the team regarding this very appreciated job, and well done. And we saved our baby. The question is, I need to ask about the time we took from door to OR or door to starting this bronchoscopy, because we have an experience like these situations. I'm working in Baptine Cardiac Center with collaboration with our centers around, like King Fahd Specialist Hospital. We had like 12-year-old girl. She had already an accident with the tracheal tear. This baby was transferred to our hospital. We put urgently on heart-lung transplant with our surgeon, ENT surgeon. He started his job and we saved our baby. So I'm asking if like these babies should be taken from door to cardiac surgery room to save the time, and with all the team inside to insert the even heart lung and start to remove the foreign body, just to save the time. I mean, is it possible? Because I know that in King Fahd Medical City, I think we have already our cardiac surgery service. Thank you.
Thanks, doctor. I'm not very clear. Are you asking about your patient in your situation? How long would it take?
No. I mean, I'm asking about your baby. No, your baby, because you know, you told me that you took your baby from emergency and then taken to ICU. You inserted the ECMO there, and then you did something like that. But if this baby was taken from the emergency to cardiac surgery OR, you got my point? To start your job there, I mean, as an emergency.
Sure. So it's totally different. Like ideal high volume center where they have the capacity, they should deploy ECMO within 1 hour. Like ideal is 30 to 45 minutes. We're talking about a patient came through the door with many challenges, unsure about her neurological status and whether it's clearly indicated or not, trying to maintain her stable, because the trip from emergency department to the children's hospital is also a long way, very, very long way. So to stabilize that patient on high frequency, trying to get her oxygenation better to 80s until people realize that 80s are not sustained. From the time we got called for the ECMO consultation to be ready for deployment was within 2 hours. But moving that patient with high frequency nitric oxide and this long trip, the arrangement with the ENT got her some time. Like the total was around 4 hours, 4 or even 5 hours. But this is with maintaining stability by the intensivist at emergency department just to get her to OR. So the ECMO deployed in OR in order to get things done together, which is put the ECMO, remove the tube, scope, and go from there. We were not in a position where we can deploy the ECMO for a first VV ECMO inside emergency department, given the resource allocation and all of that. So in other situation where you have a patient who is indicated to have VV ECMO, it will be like the moment you consult, if the patient need ECMO, it should be within 2 hours. Like our last case, it took us like within 2 hours, patient was on ECMO. And this is also if you have a cannulation issues. But if there's no cannulation issue, the getting people ready at bedside to deploy ECMO won't take more than even like 15 minutes, because everybody is available, whether it's day or night, even 1 hour is acceptable.
Okay, thank you.
If you allow me, Dr. Nada, this patient was shifted from ER to the OR directly. Then after ECMO, it's transferred to the ICU. I think this is the question of the Dr.
Yes,
Shaban.
this was my question. Yes,
yeah,
this was my question.
We shift the patient from ER with the stabilization as much as we can, and we shifted to the OR, in the cardiac OR. And then after removing the foreign body, cannulation and ECMO started, and removing the foreign body, then shifted to the ICU.
Yeah, this is yeah. Thank you so much. Thanks for this clarification. It's very important. Thank you. Thank you.
يعطيك العافية دكتور شعبان. Dr. Ali, you have a question or comment?
Yeah, thank you so much. I would like just to highlight about the question of Dr. Iman as well as Dr. Sha'ban. I think they have like two good points on term of the alternative or like what the next step we could do at this stage. So first thing, like stabilization, such cases probably need you need to go probably over the limit of mechanical ventilation. Like such patient was oxygenated with the high frequency, probably we went to like very higher setting to be oxygenated, and we're able to achieve actually like 100% autosat. But is that safe for the patient during taking off the foreign body? I don't think the patient was tolerating. He was like, if we are like getting 5 seconds or 10 seconds like during like off bagging or off mechanical ventilation, the patient brady and hypotensive during that episode. So we elect at that time to decide by like the ENT as well as the team, the BELMO and the intensivist agreement, like this patient to be on the safe situation, either on cardiopulmonary bypass or like VV ECMO support at this stage to be on the safe side. There is chance to be trying, as Dr. Iman, I think, putting like a block, bronchial block, one of the consideration, yes, but this is, if you consider this weight and this age, it will be quite difficult, as well as there is chance of losing of the ventilation, where the patient very clearly the RV was not so stable from the hemodynamic perspective. So from the safe side, putting the patient on VV ECMO as well like it is safe, able to extubate the patient completely and go for like removal of the foreign body, which taking care by the ENT without sacrificing the patient to high risk of cardiac arrest.
Thanks so much, Dr. Ali, for your comment. Dr. Saleh?
Assalamu alaikum.
Walaikum assalam wa rahmah.
Thank you very much. That's a very interesting case. Compared to the National Guard case presented the last session, I think the case has got the ideal rescue management. If you could remember the other case that was discussed, although they have very good outcome, but they took many risks. Now your case got very good rescue support, and you are lucky that all the intervention happened during the acute. So you could have, I mean, the standard rescue here, what you have done is that OR, and you could have applied the bypass immediately there. Now the lung here is healthy. So after removing the foreign body in the OR, you could have like short stay on the bypass in the OR, and the patient could have been maybe decannulated and sent to the ICU on the ventilation. This is one way, but the other way, which I agree with the previous colleagues who discussed the cardiopulmonary arrest, which is prolonged. Here, I don't know the standard from the literature review that you have conducted in terms of post-cardiac arrest. What is the best way to rescue the patient, regardless of the foreign body here? Is it the VA ECMO or VV ECMO? Since because if you have bad oxygenation and then the VV ECMO did not work, then you have to switch to the VA ECMO. Now you want to minimize the struggle for the oxygenation and to save the brain. So I don't know what is the evidence in post-cardiac arrest in such case. Do you need to go for VV as a trial, then it failed, you go for VA ECMO, or you have to go for VA ECMO from the start? Thank you.
Thanks so much, Dr. Saleh. If you allow me to answer this question, I would say, just to be clear, that this patient doesn't have healthy lung, because despite the high vent settings and the ability of transient to oxygenate. There was high CO2 retention. There is very bad compliance on bagging. There was milk established from the ATT. So the aspiration history is there as the patient was just taken from home, chalked with a toy, tried to be intubated. The second thing, that there was a use of PEEP of 17 from the referral hospital. I don't know for how long, but this patient came with 3 chest drains and bilateral pneumothoraces after 24 hours. So there is a lung damage, and we have established poor compliance on the lung and mixed respiratory failure. So the indication of VV ECMO wasn't just the rescue therapy, but it was elected to continue to rest the lung since we had deployed the VV ECMO. And the ideal situation, it should be considered either way. The indications, as Dr. Ahmed have mentioned, is not limited to, but as it is resource utilizing and it is intense in pediatric, I would say in a low volume center, the consideration is whenever the mortality with the conventional therapy and any intervention could have increased the mortality beyond 50%. So if the mortality with the conventional exceed 50%, then go for ECMO, because the mortality on ECMO is 50% or less, as in pediatric and in neonates from the ELSO registry. I don't know, the second point, I don't know why people, they think cardiopulmonary bypass is an easy. Even for cardiac surgeon, when I called him for interventional cardiology case, high risk for cardiac arrest, like aortic stenosis with very poor prognosis, he even refused those cases to open their chest while they are going through intervention. Like the usual is, okay, do the intervention. If the patient arrested, then we have to open the chest because it's life and death. But I'm not gonna electively open the chest to put cannula centrally just to do a procedure. If you are doing non-invasive procedure, we're talking about percutaneous cannulation by intensivist, which is much less invasive, regardless the ECMO complications and the deployment, but percutaneous have less risk and less complication, better healing. So percutaneous cannulation is much better than I open a sternum just to do a procedure. Even if I put him for cardiopulmonary bypass, it's like he went for cardiac surgery to remove a toy. But having a hole like a dialysis catheter in his neck and his femoral is not a big deal. There is a third point, I know maybe I missed answering that, which is post-cardiac arrest. As I mentioned, we were not clear about the data. There was no report asystole or clear bradycardia. We assume that it's hypoxemia. We talked to the doctors there. They were rushing everything because patient was blue, and they were resuscitating, trying to intubate until the patient picked up with oxygen improvement. So on our assessment after 1.5 days, if there will be low cardiac output syndrome post cardiac arrest or bad echo that we didn't have at bedside, then we could have considered VA ECMO. But the choice was VV ECMO, thinking that it's just bad lungs, and to convert to VA ECMO, it's always possible, but you need a surgeon at that point of time to cannulate a carotid because he's like less than 10 kilo. Thanks so much. I hope I answered your questions. Any other comments or questions from audience? Dr. Iman?
I would like to know what was the reason for pericardial effusion.
Dr. Ahmed, can you answer?
Yeah, thank you for the question, Dr. Iman. Actually, pericardial effusion mentioned in the literature that can be happened during ECMO support for many reasons. One of them is that the inflammatory process, and the other thing is that the irritation from the cannula to the myocardial wall that could lead to pericardial effusion in some cases. And in our case, we think it might be both, but fortunately it did not require intervention and resolved spontaneously.
Okay, thank you.
Most welcome.
There was actually a concern on the amount that we didn't have a tamponade, but the cardiology was concerned about the amount at one point, and there was discussion to remove the fluids, but no success on that. But after removing of the cannula on follow-up echo in 2 days, the pericardial effusion per se just resolved spontaneously, and there was no issues with that. We were following by PNP and systemic perfusion as well. Thanks so much for your question. Any other comments or a question? Okay. يعطيكم العافية جميعا. Thanks so much for listening. Yes.
So thank you for all audience attending today, and I would like to thank Dr. Nada as a pediatric Ecmo team in our hospital for the great effort she did. Alhamdulillah, we have established this program in our hospital, and it was a great effort from PICU team leading by Dr. Nada. So thank you a lot for her and for the team in our hospital and all support we have it. I will return back to the question of Dr. Hani Timsah about outreach program, and just assure you that it's in progress, and we're working now to establish this program with the OMOH, and we are happy to receive cases from our colleague from other center for the patient who might need VV ECMO. And we're working, inshallah, with the OMOH to establish this program already. And inshallah, we'll see the light very soon, bi'idhnillah. Again, thank for all the team and great effort. And كما في الآية الكريمة يعني ونحياك كأنما أحيا الناس جميعا. أعتقد this is an excellent case, saving the life, and the patient almost returned to the normal. At least for the family, is doing fine and active. And we saw the video before transfer the ICU. The patient was following and interactive. So all this great achievement, alhamdulillah, بفضل الله سبحانه وتعالى. And ثم بفضل المجهودات الكبيرة اللي كانت في الKfmc وكانت على رأسها الدكتورة نادر جاسم. So thank you all again for your attendance, and looking forward.
تسمح لي دكتور. تسمح لي دكتور عبد العزيز. والله that's an excellent news. First of all, really I want to congratulate you for such a wonderful news. You know, when my unit brought the CRRT many years back, I told them this is a milestone for our PICU. Now, if you bring ECMO outreach, wallahi, will be a major milestone for all our PICUs. That's wonderful news, really. الله يكتب لكم الأجر جميعا. Thank you.
آمين وياك دكتور هاني، ويعطيكم العافية جميعا، وما نستغنى عن السبورت من الجميع، والinput دائما highly appreciated for improving the program, and as intensivist, our aim to save the life and good quality of life. So thank you for all, and inshallah we'll hear this news soon بإذن الله. يعطيكم العافية جميعا. Thank you.
Thanks everyone. نختم اللقاء wishing everyone like safe practice, and hoping that we will release a trigger for ECMO consultation soon. However,
we are doing our best for all cases to avoid this intense management, but if it is indicated, it is indicated, and early deployment is better than late. Thank you. تصبحوا على خير.
Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you. أنا دي. Thank you, Abdullah.